I want to welcome everybody to our March 2026 Lunch and Learn talk here. Again, we've been doing these monthly statewide for a couple of years now. And again, lots of repeat attendees, and we've had an opportunity to have a number of great speakers, and today is no different. Our talk today, we're so fortunate. We have a much beloved friend of the COE, Dr. Trip Ake, who is joining us today, and we're so excited to have him bring his expertise and knowledge to this group. We have learned so much from him, and really excited to have him share this information and so much of this information with you all. Dr. Ake is a licensed psychologist with 20 years of experience in the field of child trauma treatment. He's a professor in the Department of Psychiatry and Behavioral Sciences at Duke University and an adjunct assistant professor in the Department of Psychiatry at Chapel Hill, which is a confusing time of year to have a foot in each of those worlds. And he is also program director at the UCLA Duke National Center for Child Traumatic Stress, which is the coordinating center for the SAMHSA National Child Traumatic Stress Network. And he serves as the director of training for the Center for Child and Family Health. He has extensive experience in providing trauma-focused mental health treatment to children and adults, and is becoming more well known for his work in using implementation science to guide selection, onboarding, and sustaining evidence-based treatments, typically used to target symptoms of secondary trauma exposure in children. So I really want encourage you all to join me in welcoming Dr. Ake to the space to share his information. So I'm going to turn it over to you.
Thank you so much, Caleb, and good afternoon, everyone. So good to see everyone here, and maybe it's still morning for some of you, depending on where in Tennessee you are. I'm just so excited to be here, and love that you all come together regularly to think about how to do this work, and so happy to be here. I always love a title with a good colon because it makes it so that you can just have more words, and sometimes wordy people have a hard time narrowing things down. So this is the title for today: was Trauma Informed Child Welfare Practice focus on screening, assessment, and crisis prevention. And just wanted to thank some folks that contributed to some of the material we'll be talking about today, as well as the COEs for the invitation. So I work, like Caleb said, for a couple different centers connected through Duke. One is the Center for Child and Family Health, which is a private nonprofit focused on prevention, intervention, and training around child trauma. And then, the one resource that I would say I hope you take away from today, if you don't already know about it, is the National Child Traumatic Stress Network, which is a public-facing resource with all kinds of content for every audience group that works with kids and families impacted by trauma. And then a couple of individuals that helped with some of the slides that I'm going to share today: Dina, Julia, and Caitlin, who I work well with, and then the North Carolina Department of Health and Human Services, as I'll be highlighting some of their work. So here's the agenda. And I'm happy with this size group for folks to also, feel free to put questions as you have them in the chat, or thoughts. I might be asking for a couple activities for folks to, contribute kind of their reflections in the chat. And then if it seems more appropriate to have a conversation off mute, then that we can entertain that for sure. So I'm hoping to start with a connection question in just a second, and then have some conversation about, when we talk about trauma-informed child and family service systems, what are those? How does that, impact how we talk about? Yes, Deborah, we'll make sure that the slides are shared, so you'll have those. For the folks that want to take notes, go for it, but you will certainly have these in your inbox at some point. And then we're going to talk about screening and assessment, what's similar, what's different, and some examples that we have from trauma-informed child welfare screening in North Carolina. We have some examples of suicide prevention screening within the network. And then we'll talk about some resources to learn more about screening in particular, and then some other kind of considerations for trauma-informed work. So here's the connection question I would love for you guys to share in the chat. What is it about your connections across Tennessee that make working with children and families more worthwhile or meaningful? Um, the power of collaboration, I think, is just so strong. And this Lunch and Learn is an example of that. And so, just curious on this kind of sunny here Friday afternoon, as you think about your connections with either folks on this call or others that you work with, um, what is it about those connections across the state that make working with kids and families more worthwhile? So I'll just take a second for you to be thinking about it, and then you can share those in the chat. This helps me to get to know you a little bit better, and also hopefully for you guys to share a little bit about the reason you show up for things like this, or that you want to stay connected. And probably some of you've already seen that the slides, our PDF of the slides are in the chat. So thanks for getting us started. Collaboration, knowing that you really can know more than you can do alone. Love that. Partnering with others helps to ensure that kiddos and families connect with services. Maybe someone else knows about a resource that I don't know. Love that. Yeah. Making appropriate referrals, since to collaborate with lots of different agencies, learning from different people, sense of togetherness, learning about programs across the state that serve child welfare and can help support with the kids that we work with, new perspectives, being able to stay in children's lives. Foster care can be so unpredictable. Yep. So helping them know something in their life is consistent makes it meaningful. Love that. Sorry. So much focus on uncertainty into the world of news, but the work reminds me that we're more alike than different. Thank you for that, Justin. And then helping professionals to having other professionals to commiserate with, Deborah. Okay, we'll take it. We'll take it. Gain insight that we might miss, others may have knowledge on. Good. So this is a group that I feel like is it's kind of like a learning organization, right? Like really thinking about making improvements by putting into practice small changes that we can make as a result of things that we're learning and learn from each other, which I think is great. And that is, and I'm seeing continue putting in the chat because I think this is good for you all to see too, not just me. What keeps us in this work? What helps us, to know that learning together is so valuable. So thank you all for participating in that. Okay, so I want to start by defining trauma-informed child and family service systems, and hopefully this will give you some grounding in what it is that, as we talk about this. So the network years ago had this great definition of kind of key areas that you would see kind of play out. And these are very action-oriented types of definitions around what are you doing if you're a trauma-informed child and family service system. So one is to recognize and respond, which really speaks to our screening, right? When we talk about recognizing, that means we have to kind of know what it is that we're dealing with. So looking at, and also then the impact of traumatic stress on those who have contact with the system, including kids, caregivers, and us as service providers, knowing that the workforce is a really important part of this equation. That we infuse and sustain trauma knowledge, awareness, and skills into our organizational culture, practice, and policy. So to me, this is kind of beyond just knowing knowing more about trauma. It really speaks to the practicing more, so that we're not just kind of throwing information at people, but we're really kind of trying some things out, which I really got from what you guys were putting in the chat, that's what this group is really interested in, which I think is amazing. And that we act in collaboration, using the best available science to maximize physical and psychological safety, facilitate the recovery of the child and family, and support their ability to thrive. And there's so much in there. Right? There's so much in that definition. But we know that some agencies that serve the same families aren't always working well together, right? And so this really speaks to how would we look to the science? Would we look to the practice? Would we look at how are kids physically safe, which I feel like we're all on board for, and then what does psychological safety look like in the work that we do, where kids are physically safe but they don't feel safe. And so, what is it about our work that can improve that? There are also these great bullets that the network came out with that I'm just going to run through in just a second, but they really drive part of what we're talking about today. And I'm just going to cover the first 7 of these. So, the first element of a trauma informed child and family service system is routinely screening for both trauma exposure and symptoms. So, I think that that's if you have to think about like what are the best things to include in a screening, those are the 2 things that the field really is kind of saying we need to look at what level of exposure kids have had to trauma and then look at how their behavior, mood, other types of symptoms are playing out to know what the impact is. And so that's what should be included in our screeners. We'll talk a little bit more about that. Using evidence based assessment and treatment for traumatic stress and associated mental health symptoms. So, using what we know works. And we have quite a lot of evidence. And I think that your best practices projects and other things like that are really geared towards making those available to children and families through the workforce that you all have. So that's great. Making resources available to children, families, and providers on trauma exposure, its impact, and treatment. I think this is probably one of the most underutilized kind of areas as we think about sharing content with groups that can really use it outside of our workforce. One of the groups that I feel like is probably the most underutilized, but probably needs some support are our resource parents, um, our foster adoptive kinship therapeutic foster parents. I'm seeing some heads nod. Thank you for cameras on and heads nodding. Um, they are often part of our workforce that I feel like carry so much of the weight, but often don't always have the tools to know how to navigate some of the behaviors that they're seeing. And I don't know. I really want for them to call child welfare less, um, with the kind of maybe you can in the chat or if you're on camera raise your hand. How many of you have received calls from someone saying I'm done today parenting? Today's my last day of parenting. Please, can somebody come pick up Johnny because I'm done today? Is that something that you're hearing of? I see some heads nodding. Yes, Deborah says in the chat. Okay. That's, I think, what it's going to take to be able to get there is for us to think about how to empower our resource parents to have some of this knowledge that we're talking about and change how they're doing their parenting work, right? So that's something we can talk some about. Engage in efforts to strengthen the resilience and protective factors of children and families impacted by and vulnerable to trauma. This is so important to know that as we talk about trauma, we also talk about resilience and that it's not one or the other as we think about trauma informed practice. It's really both. And knowing that there are so many things that we know help promote resilience. And as long as we also kind of keep perspective that kids continue to develop, they continue to grow, and that we don't have kids that are broken, right? We don't. Kids continue to develop. My 21-year-old sometimes reminds me, remember when you said that our brains are developing into our 20s? And this is like right before she advertises something that wasn't the best decision so that she can kind of justify it. But we know that kids continue to develop and to grow. Addressing parent and caregiver trauma and its impact on the family system. We know that our kids who have trauma sometimes have caregivers, whether they're their biological families or resource families that have their own trauma. And being part of a system that's addressing it is thinking about that group as well. And then thinking about continuity of care, which is something I saw in the chat earlier that people are getting from this group, which is great, in collaboration across child service systems, because there are roles that child welfare workers have that no one else does, right? No one else can do that job. And there's roles that law enforcement or mental health or CACs or advocates or other folks, whatever your role is that I'm missing is unique in this kind of work. And we need to kind of work together. And then number 7 is really such a big topic these days, around maintaining an environment of care for staff that addresses, minimizes, and treats secondary traumatic stress and increases staff wellness. Burnout, workforce turnover, those are things that are happening in North Carolina. I'm not sure that they're happening in Tennessee, but if they are, this is really what this is meant to kind of address, right? That we want to take better care of our workforce because this is hard work. We know that working with this population makes us vulnerable to stress. And we want to find a way to keep people who are doing good work to stay in the field and be able to continue doing this good work. So I think that's just an important kind of element. There's some really great content from a group called TEND, TEND, that's out of Canada. Françoise Mathieu is the director of that center, and she's the one that wrote the Compassion Fatigue workbook, if you've ever seen that. So there's some really great kind of content there. And then the network actually has a whole group, collaborative work group that's focused on secondary traumatic stress prevention. One of our network members in Kentucky, Dr. Jenny Strand, Dr. Jenny Sprang. There are 2 Jennies in our network. Sprang is the one that's in Kentucky. Her center really focuses on STS prevention. So I'd encourage you to look up some of her content as well. Okay, so I'm going to show a video. I'm going to stop sharing for just a second. I'm going to show a video because I want us to take a look at an example of what trauma can look like in a now adult. Oh, thanks, Caleb, for those resources in the chat. What trauma can look like in an adult who experienced it as a child. And I want you to focus on a couple things. How do you know that maybe Chad is experiencing or has a trauma history? And then what's making a difference for him? Okay, like what do you see making a difference? And then we'll kind of reflect on some of that in the end. So let me make sure that I can get this going.
It's just hard with that. I mean, I was just a kid. I mean, because here everybody knew our business, knew what was happening to us, and it was brutal. Oh my God, there's a school. If you go right up here, there's a turn, and you can situate it.
It's a tough thing back here.
Yeah. This is crazy. There were some good times though, like we'd have a good 30 minutes or so before we heard the sliding glass door open. And one day he came in and he actually had pizza, like supreme pizza. And another day, everything, well, he was fine. And another day he came in, for no reason, he just smashed my mom's head against that cabinet there. Just thinking of, just to the left of where they're playing, it's where my brother and I would play. My dad, he would come home and we had to be really good at sports and stuff, so. There's one time where were sitting, I knew it was coming. I knew my brother, Bobby, I knew that he would be the one to bear the brunt of it. And so I'm sorry. I'm sorry.
Chad reminds me of a lot of the kids that come through here. Angry, very angry. And you could tell he just didn't want to connect with anybody. And you could tell he was hiding something. He always came in with a nervous stomach. My stomach hurts, my stomach hurts. And he finally came clean and told me his father had major anger issues. He said, I need to talk to somebody. And I instantly thought of Coach Morrow.
Good job. Chad wasn't a football player per se. He was just a kid that had energy that needed to do something. He needed to be a part of something because I don't think he had anyone as a role model or someone showing him what to do. On the whistle.
Coach Morrow was the only person I really trusted in this town. He was always there.
Yeah. There was times I would give him a ride home. We would talk, sometimes we wouldn't talk. But it was interesting to have a discussion with someone, a young man who had no one to talk to.
He was the only one there for my graduation. Even my family wasn't there.
You're doing good. You're okay.
I just remember when you were walking across, I just remember looking up. He had this big old just ear to ear grin.
It takes a village to raise a child. And it doesn't matter what nationality, what race, we're all from the human race. If you interact with someone, it shows them that you care.
Good memories, You gotta hold on to those.
It's love thy neighbor. It's what we should do.
When's the last time you saw him?
About 8 years ago. And actually right over here is Lucille's barbecue. The best barbecue you'll ever have in your life. And Coach Morrow actually took me there, like after high school graduation. But take this right. It's gonna be your first right over there. Just pull in, not this one, but. I freaking knew it. I freaking knew it. I did too. I knew something was up.
No,
I knew something with that. I knew it. I knew y'all were doing something.
No, you didn't. There he is.
I heard you in town. I knew you couldn't pass up some Lucille's, man. Oh, good to see you. I'm so proud of you. Done well. Done well.
Okay. So I know that can be every time I watch it, I still have a little bit of emotion as I watch it, right? Because it's just it's such a neat story, and being able to see how Chad and the coach connected. What do you see? And you can put this in the chat if you really have something that's harder to type. You can come off mute. What did you see that made the difference for him, and how can systems you work in serve these children best? I feel like grounding in a real example is better to start with as we talk about this work, because it makes it more, to me, meaningful or more real. So I'm just curious. What do you think made the difference for him? Consistency and letting him share. One person to make a difference. Yes, Monica, we know the literature actually says one caring caregiver, right? In the prevention world, that it really takes one consistent caregiver. It does not have to be a parent, right? Someone listening, connection to somebody who cares, being seen by the coach. someone who took the time to ask questions, only takes one adult, investing him in being consistent, safe place, somebody who believed in him, genuine love. Yolanda, I appreciate that. Having one consistent, solid person in their life, right? These are really good. How do you think that our systems can serve kids like Chad the best? Yeah, an adult role model. Identifying early who needs extra support. Yes. Focus on relationships and less on metrics. I think so. I think looking at trying to assess early what's going on and then leveraging relationships to make change, I think is a way to maybe think about it. Showing empathy, supporting the supporters. Yes, Caleb, we have to take care of our supporters if they're going to do this work. Being a listening ear and showing up. I love that. Working to prevent domestic violence. Yeah. I think prevention work in general, which is hard to fund. It's hard to, to make space for because we have a lot in the more crisis oriented kind of spaces that ends up taking up some of our time. Not being dismissive. Good. I really appreciate that. You guys are great. Helping them feel like they're not in it alone. Yeah. So as we lean into some of this conversation today, I want you to remember Chad, starting recognizing problems in families with school-age children. Yes. I want you to think about in the systems we work, where are we identifying these things, right? So this was in a school system. That's just where it came up, right? There was a school counselor that you were seeing, by the way, that said that's because he kept coming to the office with an upset stomach or saying that his stomach hurts, which often we see that in young kids, right, as a way of talking about anxiety. That's often, it's not uncommon for young kids to present that way. But we need to think about in our systems, where are we identifying this? And what can we do to prevent more harm and to address the things that we know already exist? Okay, so I want you to be thinking of Chad as we go through today. Great. Keep the comments coming if you have them, and I'm going to move forward. So why screen? Why do we even think about screening? It helps everybody understand how trauma exposure might be impacting functioning. It helps us implement practices that we think might make a difference and guide decisions regarding clinical assessment and treatment or child welfare practice or other kind of system level practice, right? As we think about the supports that are put in place. If we know what the trauma is, we know what the reminders are, and we know the way that things play out, we can act differently to help support a kid, right? Versus Johnny's just being overreactive, right? He just needs to, he needs to be able to cope with this differently. And I see in the chat, yeah, that schools, a lot of things come up in schools, right? Because they're with the staff for full days, and we get to see what that looks like. I'm thinking after COVID, we heard a lot from the school staff about how they were really having to manage behaviors when people started coming back in person more. So I do think that that's a system that sees kids quite a lot. But here's an example as far as like if we know we can do something different, right? So we had a foster family that was having trouble at dinner time with the child in their care, and it was inconsistent. Like some nights they were having problems and other nights they weren't having problems. And they kind of worked with their therapist to think about like what are the patterns and what are the times that things might be showing up for them. And what they realized was the child was sitting at a table right across from a door in their house, and that door led to a basement. And the nights that door was open, there were problems. The nights that the door was closed, there were no problems. And in the child's history, some really bad things happened in somebody else's basement, right? So instead of kind of writing off Johnny's dinner behavior as like a problem that he needed to cope with differently, they really got to the end of like, oh, I think I know what the reminder is, and I think that maybe we can do something about that. But we wouldn't know if we don't know what the trauma history is and what the impact is. Those are things that we need to know in order to make that more meaningful. So the benefit is that it helps support placement and permanency decisions, helps our workflow. It gives us a shared language to talk about trauma history, assist our workers in sharing trauma exposure information with families, can guide discussions with youth, like the example I just gave, can give some valuable insights into behavior, that Johnny's not a bad kid. He's just scared when that door's open, right? Like he's not purposely trying to make your life harder at the dinner table. He's scared. Facilitates communication and collaboration with parents and professionals working with families in home cases. How does it actually help you to do screening? Again, you do things differently in your day-to-day work when you know about what trauma is. Does asking about trauma re-traumatize? We have a lot of evidence in the literature that asking the questions doesn't harm kids. And that we, in our practice in North Carolina at least, recommend that 6 and up is when you would probably do more direct questions in kind of broader practice, but certainly those that specialize in early childhood and trauma would know better about how to ask questions. And that in North Carolina, at least, and probably in other states, the Child and Family Services Improvement and Innovation Act requires states to monitor and treat emotional trauma. That's something that we see there, including the early identification and treatment for resilience and recovery. So what is a screener? Is short, specific, an opportunity to uncover new information. It is not long or in depth or the only chance to investigate something, right? So some examples: your blood pressure test that you do, or maybe a mammogram or routine blood test, or questions about depression or anxiety that come, at a doctor's visit. Those are the kinds of things we might see as examples of screeners that you're doing in other places. And I see in the chat now, legislation to help kids and families deal with trauma in their lives. I agree that advocates in the policy kind of spaces are great, and to know kind of what that looks like. So thank you for that comment. So we do have an NCTSN partner in Connecticut that developed a free web course for lots of audience groups, including child welfare, schools, mental health, on even just selecting a screener if you don't already have one. And it's called Screen Time. Jason Lang is the PI of that particular grant, and just wanted to provide that as a resource for you, knowing that you may already have screeners in place, but just wanted to make sure that that you know about that. And as we think about trauma treatment and screening, once you decided you need to assess further something that comes up in a trauma screening, then you would engage someone who's going to do something more involved, right? You would have someone who's going to be looking at what are all the traumatic events that we know about, what level of exposure were people kind of involved in, what are some of the symptoms or behaviors or different difficulties that are showing up. There would be a number of techniques used. So interviews, there would be standardized measures used probably. There would be observations, as we think of especially our younger kids. There are some things that we would be doing to kind of observe what their needs are. And we would ask lots of different kinds of people that know that child about how are behaviors in school as opposed to at home versus other spaces. And think about how for that child trauma might have impacted their development. And any reminders that might lead to those things. So while assessment is something that probably I would guess the COEs would know a lot about, and other providers in the state, That's really not something that you have to start with. Starting with screening is really the best kind of place. It's kind of like when you go to the doctor's office and you have this big checklist and you check one thing and then they ask you more questions about it later. It's meant to kind of the screening kind of aspect is something that most of us can be involved in. So I want to orient you to a tool that we use in North Carolina to kind of illustrate how it's put together, what kind of questions are in it, and then some of the things that we're finding. And one of the main things that we had to do when we were partnering with child welfare, and this is really coming from child welfare's perspective, not ours, is that we needed to move away from referring to the screener as a form instead of a tool. Why might that be? Why would that be an important distinction to say this is not a form that we're doing, we're using a tool? I'm gonna wait and see what the chat says. And this is coming from a mental health person that's really hung out with a lot of child welfare people, but I am not a child welfare worker, right? So you can kind of recognize that if you're in the child welfare space. Tool sounds useful, whereas forms sound like administration that won't be looked at. Tools are helpful guidelines that'll be utilized and not just filled out. Yes, correct. I hear that sometimes in our systems, things can be focused on like a compliance thing, where did you check the checkbox or not? That we did this or we did not. So we wanted it to be less of a compliance tool and more of something that would be used, like you all are saying, right? And that culturally was something we had to really focus on because there's so many forms, there's so much paperwork, and I see some people looking at me and nodding. Yes, that is true. There's so much paperwork that's happening. And so we didn't want for it to be just another form that people felt like they just had to check off they filled out. And it was something that was co-developed between the child welfare workforce and our mental health workforce so that psychologists weren't coming up with items that would be on a checklist that workers didn't have input into. So it was, yes, yep, tools that assess family needs and strengths. Yes. So we did this together. It's universally recommended for all children in child welfare, and it has helped us identify traumas that were not identified before, even for kids who've been in care for a while, when this screener was used by workers with their kids. So they have two different forms. One's for under 5, and one's for 6 and over. In the 6 and over group, you'll see when we go through the items that there are 3 main types of traumatic events that we ask kids directly about. And then there's kind of this section on history of trauma, current behavior, and then decision. Kind of what is it that we're deciding? So we know that this also helps us ensure that all kids get access to care that they need as we think about reducing bias. Okay, so here's like some examples of what it looks like. And this is for the 6 and over form. This first section is really anything that the worker either knows by interview or by the review of the case or the paperwork that would say, we know that this child has been exposed to any one of these trauma types. And there's quite a lot on there, right? As we think about all the way from physical maltreatment to human trafficking to disasters, immigration trauma. We have a lot of things that are kind of on there. What was really important that we didn't realize when we had our first drafts of this was the language was really important to get right for folks to want to use this as a screening tool. Initially, we had words like physical abuse, sexual abuse, emotional abuse, and workers were very hesitant to check those boxes. Why do you think that is? Why would a child welfare worker say, I don't think I'm going to check that box for the screener that says sexual abuse or physical abuse? I'm going to be cool. I'm going to be patient. I think one of you are going to say something here. Concern that it's not enough to warrant that label. Concerns they're certifying that the investigation founded it. Yep. Because of out of home placements, it can stop a conversation with the victim. The main thing was checking that box meant something bigger than a screener would carry, right? It was basically, we are substantiating, right? Yes, I hear that, Justin. I see that too. But if we check this box on the screener, that means that we have made a decision, we have made a recommendation, or we are finalizing something, and not something you would do on the front end without an entire case being opened or an investigation or other types of things that would happen. And so that was not our intent. We were like, we don't expect that you would have everything kind of decided in your case. And so child welfare in North Carolina said, if you change that word to maltreatment, we will check it. And so I guess I just wanted to highlight the importance of that collaboration between mental health and child welfare to say, we're not going to use this tool if you use that word. And sometimes you don't know that until you've already put it into practice, or like some group, some committee somewhere came up with something they thought would work. So I want to stress yes, that's right, Deborah. I want to stress the collaboration that this group is kind of honoring as a value is really important, so that you can educate each other about those showstoppers that no one would have ever seen coming if they hadn't brought it up. If you use that word, workers are not going to check that box. So just wanted to kind of share that. Let's see. The next kind of section for the 6 and up group, we would have them ask directly with this script. So sometimes very scary or upsetting things can happen to people. These are times when someone was hurt very badly or killed or could have been. Number 1, have you ever been hit, punched, or kicked very hard at home? Have you ever seen a family member hit, punched, or kicked very hard? Have you ever had an adult or someone bigger or older than you touch or try to touch you in areas that a bathing suit covers, or want you to touch them in those areas? And then tell me about any other scary things that have happened that we haven't already talked about. So physical abuse, sexual abuse, domestic violence, and other in general is kind of what we're talking about there. And then really trying to decide if there's kind of new events that we learned about, or something like that. We learned so much from these 4 questions. Again, even from kids that were in care. We had one worker, when we first tested this out, we had one worker ask 4 kids on her caseload these 4 questions. They had been in care for over a year, all 4 of them. 3 out of the 4 of them disclosed new events we did not know about. And then they became magic questions. Like, they were like, we need to be asking all of our kids these questions, which is why they developed this screener with us. But what we also learned, y'all, is that we had to make sure that the worker was prepared for the answers that they got. So we had to do some secondary traumatic stress training, because after one of the events that was disclosed was kind of a big deal, the worker really struggled to sleep well, to be able to like cope with the answers that she got. And so I think, just so you know, like, testing these things out in small ways before they go big can really be a good idea. The second section really focuses on behavior and mood. And then the next section that I'll show on my next slide is school kind of problems. So these are the kind of things that people know about. Yes, Johnny is not sleeping well. Yes, he is hyper. Yes, he is having mood swings. Yes, he has difficulty with authority or having excessive absences from school. So these are the things that people pretty easily know. They're here. This is something that often is better advertised than the trauma exposure. And then at the end, basically we're saying to workers, if you got an answer in the first section about trauma exposure, or you got an answer in the behavior section, then you can maybe take this to a case staffing and decide what the recommendation is. If you have sections, both 1 and 2, there's something in it where we know about an exposure, we know about behavior, then you need to make a referral for an assessment. Right. So, and then in North Carolina, we have kind of the COE equivalent as far as like training providers and evidence-based treatments is the North Carolina Child Treatment Program. So you see here that referred to a child treatment program provider or to a non-child treatment provider, just to know like how they're getting referred for that next step. So when the screening is positive, what generally happens is that we again make that referral. We document the decision and action clearly, and then if there aren't any in the county that that child lives, if there aren't any providers that know an evidence-based treatment that that we know, then we kind of try to work with who they have and think about how to make that therapy as trauma informed as possible, but also make sure that that person knows about assessment or ties back into groups like the COE that know about assessment to do our best work. If you ever come across a acronym of an intervention that you're like, I don't even know what this is or what kind of evidence it has for it, this is a great resource. The California Evidence-Based Clearinghouse, their job is to basically look at the levels of relevance for child welfare. So first, like, is this intervention relevant for the population or not? And then they're supposed to do a pretty rigorous evaluation of the science to say, is this like a really strong intervention, or is this pretty new and it's showing promise, but we don't know as much about it. So if you're ever like, what is TFCBT or what is Sparks or what is ARC or what, this is a good resource to be able to look at. And then the network also has a list of interventions, and we just started updating our fact sheets in a different format. This is part of the program that I direct at the National Center. And so we have made it a little bit easier for folks to understand, like, what's the structure, who's it made for, what are the trauma types that it treats, what's the frequency of the treatment, and then what does it take to provide, supervise, train, and sustain it? Because often we'll get a phone call or an email that says, hey, I want to be a trainer in, and then fill in the blank with any intervention, but they've never done it before, right? And so this is important to kind of know, what does it take first to learn how to do it, then to supervise it, and then train it. And so we have our developers articulate these things so that people can have that information up front. And we have a good number of our intervention fact sheets that have this new format, but we're still working on it. Okay. So how do we use a screener as a tool? And often we talk with our workforce about looking through a trauma lens, right? So if you know what the trauma type is and you know what the behaviors are looking like, then how might that be useful for foster parents or for a pediatrician or for the child welfare team? How would they do their job differently if they know about it? Also, what supports could benefit from knowing as far as different interventions or curricula for groups. And so I want to share a couple of successes so you kind of hear like what went well when it came to screening, and then I want to go through a couple different case scenarios for us to work through as a group. So one example in our state was the worker did the trauma screening. They knew about the different trauma types. They identified a placement. And basically, the example I'll give you is they had a child that needed a Spanish-speaking foster family. It's a small county. They had one. They had one foster family that was bilingual. And the initial kind of thought was, okay, we've got a placement. We know where to take the kid. Here's where we're going to go. And the worker that did the trauma screen said, wait a minute. I looked at the trauma screen, and basically the least slimy version, right, of trauma was that the child had been disciplined using dogs, right? So I'll just say it that way. The trauma screen showed that. So they asked, does this foster family have any dogs? Not only did they have dogs, they had the same breed of the dog that the child had been exposed to. So instead of rushing to kind of put the child in the car and go to this placement, they asked the family if they would be willing to crate the dogs, if they had pictures of the dogs, if they had other things like that that can make it easier for this child. So that apparently this family was like, they dressed up the dogs. Like this is they they were their fur babies. They had never crated them before, but they were open to doing that. And the child could see pictures, could hear more about the dogs. The family crated the dogs so that it would make it easier for the child to go into the home. And now the child is adopted in that home and sleeping with the dogs. But it could have gone very differently if the worker hadn't taken that screener and said, can we do this slower? Can we do this differently? Can we try to make sure that we're not going to scare a child by just walking in and saying, these aren't the same dogs, you're fine, right? And that was something the worker did differently by knowing about that information. The other success story I'll give is that we had one county that mandated all investigators use the screener for 6 and older. A worker went to a home and did an investigation and did not do the screener, was made to go back and use it, and then found information that led to the child coming in care because the caregivers were planning to traffic the child, right? But if they had not done the screener, would not have kind of come across that information. So I guess I just want to say, like, there are some real applications for each system to do their job differently based on what they know from the screeners. Okay. All right, here's some examples. What I want you to do with this, and we'll try to use the chat as best we can, is what seems important about the history for the situation? How helpful might the information be in solving the need? And how would you know about the trauma exposure without a screener? Okay. So here's the first one. 7-year-old male lives in care with foster parents and foster sister, has a positive screen for exposure to Hurricane Helene, loss of biological mother in mudslides, physical abuse by biological father from ages 2 to 5, and he's 7 now. Foster parents call you and complain about child refusing to go to school when it rains outside. They also say he seems more scared than he should when they try to talk about the consequences for not going to school. So, going back to the questions, what seems important about his history for this situation? And how helpful might this information be in helping solve the problem? What do you see? Based on what we know of his history, why is that important for this situation? He was involved in Hurricane Helene. Deborah, yeah. What is it about that? The rain, yeah. Sorry, yeah, is a trigger for the hurricanes, right? Where seems like a reasonable slow rain. The rain would equate to trauma for him. Yep, mom died of the mudslide. Rain is bad. Bad things happen when rain comes, right? So foster parent is frustrated. Kid is not going to school. It's only drizzling outside or whatever it is, right? Exactly. That loss and that experience of the hurricane means that it doesn't feel psychologically safe to go to school. Or that if I leave, maybe something bad will happen to the people who are here, right? So to me, that's the kind of information as a team member, if you know the trauma screen, exactly, fear, that we can try to at least provide a guess about why this behavior might be showing up instead of kind of reinforcing, well, you just got to make him go. You just got to make him go to school. I also like the answer doesn't necessarily need to be, we just need to keep him home every time it rains. Like there's got to be a different solution, but understanding the behavior in the context of the trauma is actually part of the solution, right? We might have more tolerance or more patience, or yeah, what are going to be some things that will help him feel safe? Yolanda, that's a great question. As we think about like promoting psychological safety and understanding what the behavior is about, versus often when we're frustrated and we're in that moment, it's hard to think of those perspectives, right? I have 2 kids. I don't always have the best perspective when it comes to the things that they're doing or why they're behaving the way that they are. But as a team member, if you know about a trauma history, that can be helpful. Okay, let's do another one. 13-year-old male currently lives with biomom. There's been a referral made to Child Protective Services, is what we call it here. I'm not sure if it's the exact same acronym there. After a neighbor called about the lack of supervision. His screening is positive for medical trauma. He was hospitalized with a medical illness on and off from 5 to 7 years old. And the biomom is genuinely concerned for the health of her child, but also struggling to find affordable health care. Her son struggles anytime he thinks he might be left alone. Sometimes he complains about stomach aches when he's nervous. Now, this isn't saying make a different decision with the investigation, whatever the investigation finds. But I guess I'm just curious, why is that trauma history important for the way this is playing out? What are some guesses you have? So mom's needing to work. Maybe he's prolonged at times during medical treatments, has had a lot of time alone during medical treatment. Yep. Might have medical debt that's preventing them from getting out of gut supervision. Fears being left because something may happen and have no one to help him. Yes. Yep. So I just want to offer that this context of like just having this one bit of information about his history can give a window into why might his behavior be showing up this way, and what are some things that we can be thinking about. I see hospital staff doesn't understand why parents may not be at the hospital, not directly. That's fine, Monica, you're good. 5 to 7 years old alone in the hospital, some. Yep. So and hospitals can be scary places, especially if you're there for long amounts of time or have to keep coming back. And maybe mom was really good and she was there a lot while he was in the hospital, and the idea of not being where mom is kind of scary, right? But those are some guesses that we might have based on this history. Okay, I think this is the last one. 15-year-old female in care, recently reunited with biomom after being in care for 2 years, initially came into care due to exposure to violence in the home and family needing support due to substance abuse problems, has a positive screen for witnessing domestic violence and physical abuse by mom's previous partners from birth to 10 years old. Biomom calls the foster family and the previous worker to ask how to calm her daughter down. And she and her new partner were disagreeing about finances, but were not violent or inappropriate. What might be important about this history for this 15-year-old? Triggers. Yeah. The whole idea of adults having a disagreement. Yes, Zarya, disagreements before might have led to violence, and trying to understand, saw it before and fears it's going to come again. But seeing people disagree might not help her to feel psychologically safe. And so this, you can even see this biomom's trying to do the right thing by reaching out to the previous caregiver and saying, well, how did you calm her down when she was upset? Right? Like, she doesn't understand, like, what am I supposed to do so that I can make sure that she get what she needs? But this perspective of what's happening based on the trauma screen can be helpful, as we think about, but we have to use it. We have to go back and look at it, and we have to do it. We have to do the screening, but then we have to like refer to it and think about it and use it in our decision making, so that we're not forgetting what else might help us explain what's happening in front of us. Okay. Questions so far, because I'm going to shift gears to suicide prevention as an extension of some of this kind of screening and discussion, but I want to make sure that I'm on the same page as where you are. Folks tracking okay? Are we in a good place? Okay. All right. So in the literature these days, suicide prevention is a significant need. It has been a need for a very long time, but I feel like since COVID, we see even more examples. You can see these two here, right? Of the 2024 guidelines for pediatricians really kind of outlines different risk factors and thinks about suicide and suicide risk. We see meta-analyses like this one in 2023 that shows increased symptoms of depression and anxiety for teens and children, and how COVID had a major influence on that. And so one of our partners in the network in Utah, Brooks Keeshan, has this pediatric care process model. It's not the only model out there, but it's a good one. They use it with pediatricians and psychiatrists and other folks, but they also kind of talk about this is a model that lots of other systems can use and be thinking about. And what I wanted to highlight is this stratification of how they make decisions on what kind of approach they're referring based on the scores on some of their screening tools, including an item around suicide or thoughts of suicide. And so you can see, like, they have a protective approach for those with mild symptoms as they think about just strength-based guidance. Or maybe for moderate symptoms, they would take this resilient approach where they're referring to community mental health. Or if it's more restorative, like it's at the severe kind of symptoms, then they would refer to a specific evidence-based treatment. And I thought that was a really interesting way of like guiding decisions based on how they use their tools, and would really encourage us to think about like what are the other kinds of supports that we have for kids that aren't at the highest level of need, but that could use support so that they can kind of get some of their needs met. The other thing that I wanted to highlight is the network has been focused on suicide prevention this grant cycle, these last several years. And we did a Change Collaborative on trauma-informed suicide prevention and healing. They were really grounded in some real stories that we had from some of our faculty and network members about just how many kids were in emergency departments for days and days, or how many kids were sleeping in child welfare offices with child welfare workers because there weren't placements, but they were at high risk, or some of those types of things. So different kind of crises that were happening. And so there are two different kind of main areas, without going into like, that will be maybe another talk about the actual Change Collaborative, but some main areas that we focused in on were these foundational areas of change. And then we also focused on practice-based areas of change. The foundational areas were trying to think about honoring strengths and realities in communities, to think about in the community they came from, who are the natural people that families go to for help, right? Is that a pastor, or is it a community healer, or is it in a tribal kind of community, like is it someone else, versus only kind of a mental health or hospital based kind of a approach to start from the prevention end there. Because what we were hearing is once people came out of their community into the hospital setting, depending on their experience, they were much less likely to go back. right? Because of how that kind of process looks. So really thinking about what is in the community that we can build on. Where are people already seeking help? Also, some of the differences in what risks were surrounding a particular community. So if you think about like, um, where are the most injuries and deaths coming from in this community versus another one, where maybe in a rural community, it's really um, one set of things that we need to be worried about. And in another urban community, we're worried about something different when it comes to access for suicide attempts or other things like that. And recognizing that sometimes the experience of families in our existing systems makes it harder for them to engage. So that's kind of one foundational kind of area. And then we have this whole other section focused on how do we respond to acute needs through a community-based response team, maybe, or thinking about connections to supports outside of mental health, or engaging in more transparent discussion about how services are engaged. So that we had some teams that tested small changes in their community to kind of see what would happen. And I'm going to share one outcome or one story from one of our teams. They had this group in the school. Maybe you've heard of it because I think it's a national group and you can have different chapters in your school called a Hope Squad. Have you guys heard of that before? So Hope Squads are made up of staff and students. Where basically in this school, in one of our teams, now they've gotten to the place where it's competitive for students to want to be part of the Hope Squad. And they actually have an application that goes out every fall, and they have to like engage the upperclassmen that were in the previous kind of group to help select the people that they think that are most ready to help with this work. And basically they're helping to educate other students about when to seek help when they're having problems, and also to be on the lookout for warning signs about what might be happening. So I think it's such an innovative, interesting thing. And this particular community had one of their students die by suicide, which is one of the big motivators for them to engage in this work. And so they've been doing it for a few years now. And this is one of the things that they did. So they actually went to basketball games and set up booths where they knew students and staff and parents were just going to be in a healthy place, and asked them to answer this question: what do you wish adults in our community understood about mental health challenges for teens? And these are a couple of the real answers they got from students, from high school students. That it's something serious and very real and prevalent within our community, and no matter how put together someone may look, they can still face mental health challenges. This school is one with high performers, like really, really smart kids that are doing really well, and the kinds of things that we would kind of point to and say, I'm not really sure what kind of suicide prevention work they really need, because it seems like from the outside they're doing well. But this is what the students are saying. No matter how put together people might seem, we need, we face mental health challenges. The other quote was, the stressors that affect teenagers are a lot different than what adults may face, but still are valid and imminent rather than simply dismissible. So I guess I just want to highlight sometimes community-based prevention efforts, how we join in with those or kind of partner with folks, can really make a difference in educating the folks that we're most concerned about, and to get input from so that we might change what we're doing. So just wanted to give you an example. Okay. And then my last section, and I know we're getting close on time, so I'll try to go through quick so I have some time for questions. Other considerations. There's this whole other, as we think about trauma screening and assessment and crisis prevention kind of work, there's all these other things to keep in mind, right? And so I just want to kind of touch on a few things to keep your thinking appetite ready and kind of moving forward. So as we think about trauma-informed care, we see a lot of publications starting to come out in this area, right? So this is one from one of our network members, Heather Forkey, who actually published in the American Academy of Pediatrics about the role of psychotropic medications, but also trauma-informed examinations, like how we might go about in pediatric practice thinking about what's a trauma-informed approach. And then a couple of our colleagues, Jason Lang and Rochelle Hansen, 10 years ago, and then again this year, did this study on like what is trauma-informed care. 10 years ago, they were like, other than physical safety, most of the elements of trauma-informed care were not easily distinguishable. Like they weren't easy to pull apart and kind of be distinct. And they were saying in the paper they just did this year that trauma-informed care has become a major push in a lot of places, but the research has not caught up with the practice. So that more and more people are practicing trauma-informed care, but we know less about some of the practices that people are using. So I just thought it was really interesting to know that it is a way that people are thinking. But we see examples in our network of people in courts that are thinking about trauma-informed juvenile court self-assessments, right? About how do we look at it through that lens. We see law enforcement thinking about what does trauma-informed first responding look like, and how do we notice kids on scene, and how do we think about how the adults interface with them. We see it in schools as we think about trauma-informed schools frameworks, and how do we use the tier system to map on to the supports that we offer kids and families. We also see a huge interest in how do we know that our agency is trauma-informed? And so there's this whole focus on trauma-informed organizational assessments. Network members have been really engaging this tool in practice to kind of assess their entire staff and then think about the approaches that they might do to impact any one of these domains that seems to be an area of need. As we think about implementation science, we know that there's a lot of things that contribute to people being able to do new practices and do them well, right? As we think about screening practice, even. I think I told you about that language item on our checklist. If we had not found that, we would have been scratching our heads about why is nobody in child welfare using this form that they're mandated to use, right? So that kind of inner context is like what's happening in the agency. But then I think I saw in the chat earlier, there's a lot of things in the outer context these days that are also impacting our practice, impacting our stress levels, impacting our funding, things like that. So I think that those are just important to name. There's a whole science also today on de-implementation, where I don't know if you guys have ever had this opportunity or not, but sometimes in the roles I've been in, I've got 10 things on my plate, and that's as big as my plate is. And somebody comes up and says, hey, there are 5 more things that I want to put on your plate. The practice of de-implementation is, how do you get things off of your plate as an agency to make room for the new things? And that it takes some time to actually do. So there's actual science on that. If some of this implementation stuff seems like really kind of high level and like I don't even understand like what it is that is happening there, we were able to develop this set of implementation videos that are 5 minutes or less on some of the main kind of topic areas that help people understand, like when we talk about agency readiness, or we talk about championing senior leaders, or we talk about like different things like that. What is that about, and how do people use it? So these are people who are actually using implementation to inform their work, and they can kind of give examples of folks from the network. This is one of my favorite quotes. And the reason is, like, no matter what I can tell you today, you know your agency best. You know your organization best, right? So if I bring in a new practice and say, I think you should try this, some of you say, yes, I think that would work in our agency. Others of you might say, you don't know our agency, and I'm just going to tell you the culture of our agency would probably say no to that practice. And so culture eats strategy for breakfast is one of my favorite quotes, because I think sometimes it's true that if we don't think about the culture of our agency and what it's ready to do, then I think that that's important. And then workforce wellness. As we think about asking people to do new things like screening, as we think about asking people to do for more in-depth assessments. How are we considering our workforce in this? And so there's this practice that the network has kind of put out. It's called Pause, Reset, and Nourish, PRN. It's and basically here's some examples of what it would look like. So taking deep breaths and checking your body would be kind of a pause moment. Resetting so that you're engaging in gratitude, kind of focusing, or distraction through watching something funny. Something I've been doing lately is looking at a picture, y'all, of this puppy. I'm going to show you this picture. I don't know why I'm doing this on a recorded webinar, but I'm going to do it anyway. This is a puppy that we are bringing home in 2 weeks to our house. Right now, it's very calming to look at this picture because it's something that brings me joy. I'm not sure in 2 weeks if that's going to be as calming. We'll see. But thinking about those kind of distraction moments and then nourishing about like, what do I need to do to nourish myself right now? Thinking about what's rewarding about the work that we're doing, honoring those that we've worked with or those who've passed, celebrating small victories. So this is like a quick strategy. It's one of many, but as we think about wellness of our workforce, we do have to think about how do we take care of our groups. Okay, so this is my email address. I'm going to take down the slides. I go by Tripp, but my formal name is George. If you're wondering, like, why is your name George on that slide? But I'm curious, what are some of your reactions? What are some of your questions? How does this apply to some of your work? We've got about 10 minutes. We can do some of that in. I feel like I've just thrown a bunch of information at you, so. But I'm curious, like, how is this landing for you? What do you feel like you're taking away, or you're more curious about, or you want to think more about? And this might be a moment, either you can put something in the chat, or if you feel like you have something you'd rather ask off mute, I think this is probably a good time to do that. I'd not heard of agencies trying to utilize structures already in place in the community. Yeah, Deborah, I'm glad that that's something that stands out of like, because that's where kids are going back to when they finish their assessment. They're going right back into the community. And so, and maybe that's a question we could think about asking about, like, where are the places you find support in your community, or like, is there somebody else on your list? Oh, I can put my email in the chat. Sure. There you go. The importance of assessments and using them to help individuals. Yeah. Yeah, because sometimes they can feel very technical, or they can feel very like removed from how we can actually do something with that information. And I just wanted to demonstrate, even just with a little bit of information from a screener, how much that can impact our regular work. So that makes a lot of sense. Can be overwhelming to think about all the changes that are needed and the gap that exists between where we are and what good looks like. What do you feel is most practical step each of us could take as providers to have the most immediate impact? Yes, that's a great question, Justin. I mean, I would just say start with what's one area of practice that you would want to make changes in. And then what's one small thing you can test and then study to see if it's making an improvement. Because I think a lot of times we go straight to what's the big change that all of us have to make today? And that screener that's now a formal form that every county in our state uses came from one worker asking 4 kids on her caseload 4 questions. That's where that screener was born from. But it wasn't from a committee that put a screener together and then made a policy change for all 100 counties in our state to have to do that. So I hope that helps answer, but that's a great question. Like the Hope Squad was asking questions to high school students, go straight to the source. When we make our methods very formal, we miss what's right in front of us. Yeah. Or we don't have the opportunity to even connect with the people that we think might have good answers or suggestions. So I love that. And see using that assessment as a tool from some of my CASA cases. Good. I'm glad that that might be able to be helpful. Being new to DCS, trying to navigate when the process and the assessment is most practical, beneficial to recommend as a resource. Good. Maybe we know what needs to happen, but maybe the red tape or policies, culture keep us from implementing those changes. So Monica, I really want to highlight that because in order to test things, you have to have some permission for innovation. And as a non-child welfare worker, what I learned in North Carolina is that if it's not in the policy, then it's hard to make a practice. And so I would say, where are the small places we can make for innovation without having to have a policy to drive the practice, knowing that sometimes that's hard to make happen. But I hear what you're saying. In North Carolina, it's like if there's not a policy, we shouldn't try. And we're like, uh-oh. Well, some of the other workers at the high level at the state, they were innovating. They were testing some things out. And so I think that's important to think about. Assessment can be used across the individual's lifespan. Yes, very helpful. Small things can have a big impact. Love this. According to share with CASA volunteers. Caleb, I don't know if you want to answer that. Oh, you did. Got it. I'm just not catching up with all the chats yet. I'm slower in reading. And an assessment that forms itself over time. Yeah, so I think that's a great point around assessment isn't a one and done kind of experience. It's really something that we're continually asking and refining so that we can see what the needs are, versus it's, oh, Yolanda's asking, did you say it's easier to test if you have a policy for it? I think what I was saying is sometimes testing new strategies is hard because the culture sometimes in our agencies is you can't do something unless there's a policy for it. And I'm saying, I think it's best if you can create permission to innovate or try new things before a policy's been developed, knowing that sometimes that helps inform the best policy if you've tested it to find out what works. But that's sometimes really hard to convince people of when they work mainly in a policy-driven practice system. So if it's around, yeah, good. If it's around screening, you have other states. There's actually a paper that Jason Lang and me and other folks wrote on like 4 or 5 different states that did screening practice. So you have some evidence to kind of pull from to say we have other folks in the network or we have other folks in the literature that have tried this in child welfare and seen promise from it. But initially trying to do anything new, if it didn't have a policy, makes it harder. One day I may see a youth, the next day they're gone. What advice can you give if the youth have experienced trauma? Yeah, I think that, Eugenia, that's something I would imagine many of us had that experience of, like, maybe we did an assessment and they're supposed to come back and they don't, or maybe we just see them for that one point in time. And I guess the main thing I would say is maybe lead with a question like, what's something I can do right now that would help you feel safer? That's what I would say in all these different, like to have a trauma-informed response to someone, even if it's a single intervention or single session we have with them, because you may learn something in that moment of like, oh, just sitting somewhere different in this room would make me feel more comfortable, or just ask, and knowing that somebody will ask me that question because I might answer it, can make a difference for kids kind of longer term. And we can share some of that insight with other people if we learn, actually, I would feel safer if people would stop asking me while I'm misbehaving, or those types of things. So, okay, I'm going to pause. Caleb, are there some things that you wanted to wrap things up with, or that you want to make sure to share as we're getting close to the end of our time?
Yes, there are a couple of things I wanted to highlight. But first, I really wanted to thank you for doing this talk. There's so much good information in here, and I really appreciate like your ability to kind of synthesize all of this and make it very presentable. I mean, there's so many things on here. I knew little bits and pieces of some of that stuff, but there were lots of stuff on there that was completely new. So
Great.
I really appreciate you taking the time to share that and everybody's engagement in the chat. I think people asked really good questions and did a lot of really good engagement, which I really appreciate. It makes all of these talks go better when people are engaging and being thoughtful about things. So thank you to everybody who showed up today and participated as well. I did put in the chat a link to our survey for today, just to give us some feedback on how you all felt like things went today, what you learned, what you're walking away with, what we can do differently next time, and what other topics you'd like to see us present on in the future. I will be posting a recording of this talk today at some point once I have time to kind of digest it and edit it. I'll be able to post that. The certificate will appear on your screen once you do the survey. You need to save that certificate for your records. So it's not going to be emailed to you, but it'll appear once you've completed that survey. So you can save it for your own records and it'll be there. I also wanted to let everybody know that next month's Lunch and Learn is going to be canceled. We're not doing next month's Lunch and Learn in April, but we are excited. I can officially announce we've got a series of 16 talks that we're going to be hosting between now and September. So we're going to be doing these a little bit more than the second Friday of every month for the next little bit. We were able to get a grant from Department of Health that funds some of that. So we're going to be bringing in more outside speakers, so you don't have to listen to the COE voices all the time. So I'm excited to be able to expand that, and hopefully sometime in the next month I'll be able to, if you're on our mailing list, I'll send you an email announcement with a list of the different speakers that are upcoming so that you can pick and choose what you want to come to and how to register for each of those things. But I just wanted to thank everybody for coming, and thank you so much, Dr. Ake, for presenting. I really, really appreciate this topic, and I imagine this is one that's going to get viewed many, many times on the recording because I know there are a lot of people who spring break or otherwise couldn't make it. So I'm really excited to be able to offer that as well. So thank you so much for your time, and
Of course.
thank you everybody for being here. Yeah,
thank you.
We'll stick around for a few minutes if anybody has any problems or difficulties with the surveys. And then we will gracefully boot you to the waiting room so we can debrief very briefly. So
thank you guys. Have a wonderful rest of your Friday and weekend.
Yeah.